technology is required for a patient who wants to dial in web. However this is happening, is it Skype, is it directly on the web? Do they need, what kind of cameras do they need? What kind of bandwidth do they need? How far away can they be? I saw from your network that someone in North Dakota could be miles and miles away from the pop. How does this work for remote locations?
It's a two-part question, and actually I think
There's a couple of pieces that
yeah, I'll talk to the network component, and then as far as systems compatibility and equipment requirements, the telemedicine equipment, folks can talk to that. From a network perspective, when you have a WAN, a wide area network, that all of the doctors' offices and hospitals and et cetera are sharing, also connected to that is going to be an internet connection that gives them access to anyone in the world. So once you're sitting on the WAN, the user that's coming in from the web, they can have any internet connection, which is ubiquitous. And at that point, they're going to get brought into based on whom they're trying to reach, which is driven by either the website or the advertising or what have you, whatever link or whatever they click on to get there. They're going to come into that WAN and hit that firewall and be authenticated based on whatever credentials they put in.
Does a DSL line work?
Any internet connection can, yes.
It's got enough bandwidth and pixel density to accurately reflect in dermatology, for example. One of the examples was them showing a rash or something like that. That's all.
Howard, dermatology is mostly store and forward, so if you have a DSL line, it might take a little longer, but it certainly is going to support it, and you're not going to lose you're not going to lose anything in terms of the transmission. Like Jehmal said, this is certainly this does work internationally. I've had the opportunity to work with a teleradiology company that had doctors in Spain and Belgium and Israel, and they were a reliable part of our network. They had connectivity. It was their daytime during our nighttime. So regularly we're meeting pretty strict SLAs in terms of turnaround time requirements and depending on overseas networks. But Joe, if you want to talk about what's going on in the home.
No, I think you raise a valid point, and it's something that providers, it's the weakest link in the chain, which is the consumer's endpoint, and not having control over that. And whether you're Cisco or whether you're me, we'll never have control over that. I think, though, that there's enough historical evidence, and there's certainly Obama announced last week a $125 million effort to extend broadband into a greater coverage of rural areas in the United States. But as far as telehealth is concerned, the Indian reservations across the country were really the proving grounds for a great many telehealth executions from the very start. So, yeah, it's a valid point, and depending upon the system you install, ours is purely software-based, and so it's susceptible to those kinds of things. We also built it to be very, very light, so that the video quality can still be delivered even over a dial-up. So, provided you have, some kind of connectivity, there's a good chance it'll work. I mean, recognizing everything breaks.
There's a need for some kind of reliable connection, right? If you don't have a reliable DSL cable or whatever, you're going to be good running these issues.
I think that there's a large population in this country that does not have that kind of communication capability, but has a huge need.
I think, though, that there's millions of dollars by companies getting invested in improving network, getting the bandwidth out more to rural areas and everything. That's been something that's been happening for years. I agree with you, but I think it's continuing to get better, and it will get better. There's a lot of need out there, and that's what's driving a lot of this stuff too.
Howard, let me go back for a second to radiology, especially since we have a radiologist in the room with us now. Dr. Dinhofer, are you sometimes working from home, and do you have the bandwidth that you need, and have you made any special provisions to do
I've
that?
had no problem, with the teleradiology that I've done, I've had no problem downloading images, so that's using standard DSL lines, not the, I haven't tried on the wireless yet, so the standard DSL lines, no problem running, CT scans with 1,000 images, so I can do that, yes.
Well, the discussion's been focused here on mostly connectivity. I mean, connectivity is really the issue, whether it be rural, whether it be local, whether it be who controls what portion of the connectivity. And that seems to be a central theme, not just in telemedicine, but in almost every aspect of business today. The internet is being used as a term that's ubiquitous to industry and moving the ball forward. Question for the panel, in terms of international connectivity, you have a lot of teleradiologists that are not located within the borders of the United States. How does that work? How does the connectivity flow? I mean, I've been on Skype calls that have all of a sudden vanished, and I'm sure we've all had that issue, and email seems to be pretty reliable. What about the visual imagery and all the connectivity involved in international communications?
Yeah, I can talk to that. So if you have to look at it from two different architecture perspectives. If it's the internet and you're talking about transferring images, CT scans, telemedicine scans, or telemedicine images, where it's something that you're sending across the pond, and then having it, as you mentioned earlier, stored forward. Effectively, it gets cached. Unless you're looking at something real time, you're looking at a real time video. And again, we're talking about the web first, just using the internet as your transport network. Because again, the internet is ubiquitous, it's worldwide. The standards that drive communication, regardless of where the two endpoints are, is an international accepted standard. So if you're talking about real-time video internationally, you're going to get as good as the internet can offer you. It is really that simple. It's the difference between having a private network and doing it across the web.
Understood.
So with that said, if it's a real-time video, it's the best you're going to get based on whatever's available to you, based on the endpoints and the transport, and then the distance overall.
Just
milliseconds
geographic.
and latency, it geographically it plays a role. If you are transferring a image, picture, image, scan, radiology, what have you, it gets cached and it gets there when it gets there. It doesn't necessarily have to be real time, so nothing is lost unless you actually have a problem in the network. Then you're going to have packet loss and it will distort what you receive. But that's an entirely different concern. If it's done over a wide area network, a private network, where you can apply your own standards, your own QoS and things along that line, then the transport for a real-time video, a real-time image, is leaps and bounds better because we can control that transport, even internationally. I have customers that have locations in London and Singapore, and the millisecond round trip for those type of deliveries in 80 millisecond range, which is awesome for even video and VoIP calls.
Mm-hmm.
So in that instance, we don't have challenges there on a wide area network. But again, if you're talking any patient, any patient in the world, they're not sitting on your WAN, they're sitting on the web. In which
Sure.
case, if they're sending you an image, there's no degradation unless there's actually a network problem. If they are trying to do real-time video across the web, then again, the rules of the internet apply.
I think Jehmal could talk to this all day.
Les, let me just add on that, because, when you talk about, radiology, we touched a little bit on international. Before you get the connectivity, you also have to look at some regulations with regards to reimbursement. There are two types of radiology reports that get issued: preliminary report and a final report. CMS, which is the funding agency for Medicare and Medicaid, basically the largest payer in the country, will only provide reimbursement on a radiology report, on a final report, if the physician is physically located in the US or in a US territory. So if Dr. Dinhofer, who has, decides to go on vacation to London, has wonderful connectivity there, legally he can't issue the report if he is not on US soil. So first you have a regulatory and reimbursement issue, but again, then once you resolve that, you start looking at the connectivity business.
I think the topic of reimbursement and billable time and how people pay, when they pay, is a really new paradigm. And Joe, my question is kind of to you. When I used to go to the doctor's office, I used to see the physician, he performed a service, and I went to the little window and paid my copay. Well, if the patient is not on the premises, and the doctor is someplace in cyberspace, and the patient receives a service, and then payment becomes somewhat problematic, so now you're into electronic payment, which is a whole different aspect of this whole teleradiology, telemedicine service structure. Are you aware of any sort of rules, regulations, configurations concerning electronic payment and how physicians designate their time and can quantify their time that they performed a service and for reimbursement?
Yeah, well, I think there's two parts to this question as well. One is, physician-to-physician types of services, teleradiology. I think the other is with regards to consumer payment, and that's sort of coverage. And of course, licensure plays into this. Part of your question was, depending on where the physician's located or the patient's located, it raises all the licensure issues. And so I think it's different for different scenarios.
Well, like you mentioned in your presentation, you've got one critical care group that has multiple locations.
Mm-hmm.
If, for instance, some of those critical care locations happen to be in different states,
Mm-hmm.
how does the licensing work?
Well, then again, any physician delivering service has to be licensed in the location of the patient. So doc may be in New York, patient's in Illinois, doc's got to be licensed in Illinois in order to deliver that service and expect reimbursement for it.
I think so they've changed that rule in the past, CMS passed a law not too long ago, because forwarded by one of the representatives, that cross-border telemedicine is allowed.
Yeah, and I know that it's a very big topic on a federal level to address it broadly, so I have no doubt that things are changing rapidly.
Let me reach into
We
the...
haven't answered that yet.
Also, the state of Maryland it's a law now. If a physician, it comes from primary care physician to a specialist that is outside the state, then the specialist does not need to be licensed in the state of Maryland to be a consultation. That's a new thing that happened like 10 months ago.
Yeah.
And there are other states in the Midwest that are doing that, they're trying to get that.
It's changing by the day, I agree with
It's
you.
changing
In 20 states have already done
Yeah,
it.
so it's
Get
a
off the
trend, and I
licensing
think.
thing and figure out the payment model. That's what,
I have an answer for that, because the example you gave before, vaccinations with telemedicine is not comparing apples with oranges, but correctly you mentioned that the
no, he was
deductibles.
talking about the copay, what
Yes.
people pay for an office.
Yeah,
And
well,
I
I have
said
an
that
answer.
model is completely outdated, and this is what an office visit now costs. According to Obamacare, there
Correct.
is no copay. You have to come up
And
with
pay,
$2,500
correct, but
deductible.
then the patient has to, it will go to consumer-driven care, where the patient has to make a decision, all right, if I go to that doctor's office, it's gonna cost me $150 to $200, but for this minor thing, like a pink eye or whatever, a rash, I'm not that sick to go to the emergency room. If I pay either just to go online and pay like $50 to do this, the same thing, or if my employer is good enough to buy me the plan and get 3 visits, telemedicine visits that my company is doing right now, I get 3 visits and talk to a physician 3 times without paying anything. So what the
They can't
consumer
write
will do?
prescriptions unless they see you. And in your example,
We
with the
could-
pink eye, let's just use that example. That means I've wasted whatever copay for a telemedicine or teleconference visit I still have to get into the office to
No,
get
no, it's not just
this.
because you can send image on my
Right.
platform, can send image of the guy is gonna get reviewed and then you can get a prescription.
Now, let me correct you, I'm a pediatrician, right? I would say at least 25% of my practice is over phone. So parents are gonna call me at 11 o'clock, at 9, 10 o'clock, my kid has this, and I'm calling my medicine, whether they're talking about spectro or ear infection. I'll call them at 24-hour pharmacy without seeing the patient, and they're going to tell the medicine. So we
That's
have-
not it.
That's very
That's not it.
No, it's basically.
Common doctor.
Yep.
All the time.
Common sense.
Most of the prescriptions from a pediatric point of view, 25% of them are followed over the phone.
Well, I think for a strep test, a strep throat requires a strep test. That's what
Yeah.
it was.
Not necessarily. I mean, there
I
are,
may or may not be taking just a picture.
The guidelines for the
Could be a
strep test, the
stop.
rabies strep test, if it's negative, then you need a culture. So even if it's negative, it doesn't mean it's not strep throat. So there you go. It becomes like it's a judgment call, for the physician to decide what to do.
And the other question I have is insurance agreements. How many, there are 8 physicians in the room, is that what I heard?
At
How
least
many of
3
you-
that I recognize.
How many of you know that your malpractice contract states that you can and cannot do as far as communication with your patients?
see, there is a code, for billable code on telephone. If I do a telephone consult, for a patient, I have to put in a code and bill the insurance company. Reimbursement is to people, so they offer bill.
Right, but some practices are not permitted to write in email to their specific patients.
Yes.
So, right, so if that's an email, what is the difference? And this is what I want, you're looking at, if you have a specific concern over privacy because of email communication to a consumer, what about video? How is that much different? So, as we all talk about this ability to have FaceTime with your doctor, they can't even write you, whether it be a text or even an email, you have to look at the other realities that exist in this industry that may prevent this from launching into some widespread.
But wouldn't it be fair to say that the industry is changing and that a lot of these things are new?
Until tort reform really becomes the priority of everyone that's in this ecosystem, a lot of initiatives are gonna have difficulty getting off the ground. All it takes is one lawsuit to complete.
I think the rule of thumb is that technology is outpacing legislation. There's lots of HIPAA-compliant text technologies out there, HIPAA-compliant email technologies out there. Ours is a HIPAA-compliant video chat technology, but legislation around licensure, evolution of payment models, those kinds of things it's just hard to keep up.
I think the medical community looks at it probably differently than most business communities. Business communities require that model to be determined before all the solutions start to be developed, because that's a lot of money to allocate to businesses that may or may not ever be able to make their businesses and their solutions scalable. So I'm not in this background, I'm not in the medical community, I'm a consumer app. So I take those experiences and that sort of model with me. So when I listen to people in healthcare, it's a very different approach to creating things that may or may never be embraced by a lot of practices to make it profitable.
Nikos.
That's really true. B2C, from the healthcare, we try to do B2C, that's it. You're right about it, because people are not gonna buy just anything, even for the shoes or whatever, they're very picky, they wanna look at right color, like, I guess if you're a consumer, you've seen this again and again, that they're very picky, and so.
Well, you have to have who's paying and prove the payment before you get investors.
So that's
Medicine is
why
very
you gotta-
different.
Well, when you say before you get investors, I've now identified 20 companies in the consumer telehealth market. There's a company called MD Live that also raised over $20 million and has the backing of John Scully as part of this. So there are investors that are jumping in, figuring out the models, figuring out the
As they go.
the
Right?
reimbursement
Only in
as
this
they go.
industry do you find that?
As
No,
they
it's
go.
not true.
Let me share my experience. I have a company, it's a telemedicine company, I'm operating in New York, I have it in Jersey, my name is Bigley. I'm the founder and CEO. And the B2C is very hard, and I I knew it, and it's like my main effort is going through either employer or add it as a benefit plan to them. That's a target, that's the growth opportunity. And if you're going to look at leaders of this industry, like Telehealth is, it's been out there for 12 years, as the leading leader in telemedicine. That's what they do. They go to union and they get the members like 200, 300, or 1,000 members, and that's how they do it. So it's a B2B model that's going to be viable. I agree with you. And I think that Obamacare helps us to do that because now people have to pay for their pocket and they want to look at the most cost-effective way to get the care. You know, if somebody has a chronic ailment like recurrent sinus infection, they know what they have and they want to call, need some treatment for that, then telemedicine is the way to go because it's much more affordable.
We told everybody we were going to finish at 10. I want to just respect everybody's time, and we have the room, you know, if you want to continue the conversation, but if anybody needs to get to what they do for a living, you know, we won't be insulted, but there's a question.
So far, things have been talked about in terms of either say physician to physician or physician to patient. The patient who could be a likely candidate for some of these online services could be an 80-year-old person who's not so tech-savvy, daughter, who can you address how they could be included in the loop of this?
Well, I mean, one of the things, yeah.
I can answer that just because my mother was recently a patient. And she had access to the patient network at Sloan Kettering. But all she had to do was give me the password. So I could access all her data. So I was her health proxy and I could do that. So it's a matter of, if you say, that's the important part, is having the advocate. So the problem will be the person who doesn't have the advocate, the son, the daughter, or the friend.
One of the things, I mean, I'm pretty familiar with Joe's development plan. One of the things that's high on the list for this year is to enable multi-party conversations. And that could include a translator. One of the things we're looking to do is to be able to have a conversation with a radiologist, a referring physician, and a patient where they could, display a live exam. It could include a family member, but I'll also, I've got an 85-year-old mom who's determined on learning how to use a Kindle, and we're struggling. If I'm there next to her, she's great, but
She's got a Mayday button now, which is live video assistance.
I become the call center, so that.
Are there any other questions?
I just got one quick question.
Yes.
So who is the consumer today for telemedicine? Because we know down the road, as people, I guess my children, they'll expect instant access because that's what they get today. But today's aging population, the people who really need the telemedicine, as you just said, are not going to embrace it. Even doctors are slow adapters to new technology. So who are you guys actually going after today? Is it the employer that's going after the consumer savvy patient? I'm just curious. I know it's
That's where I
question
see
that
a lot of traction.
Yeah.
Because of the issues around reimbursement.
Yeah.
If it's a employer, my wife works for Bloomberg.
Sure.
Not for the mayor, but the company.
understand.
And they just instituted a telehealth benefit to employees. Previously, they have 3 locations in Manhattan. They had a physician that spent 1/3 of his day at each location each day. But just, I think end of February, they launched a telemedicine employee benefit. And I think where, corporations get involved, things move a lot faster.
Yeah. Do you go after direct pay physicians or consumer physicians, or I'm saying concierge physicians, where the consumer's actually paying them, so it's no like
I've
service
often
they're
thought of
offering?
that, but it would be a typical, it would be less friction.
Yeah. What about the other end of that spectrum, the ACOs, where it's not necessarily about?
ACOs are a primary target for us.
Okay.
Yeah,
Okay, so I can see that too.
yeah, where they're motivated.
Yeah.
And that's why Intermountain, I think, is a leader in this space. Not only do they own the 17 hospitals and 130 clinics in Utah and employ anyone who's in healthcare in the state, they're also the payer.
Yeah, I understand.
So
Yeah.
they're motivated.
They get skin in the game.
Exactly. Yeah, so I think the ACO model will drive a lot of it.
I just think it's the middle ground guy that's stuck in the
Well,
reimbursement.
the other,
Yeah.
They're not gonna jump on
payment
it.
issue is
Sure.
also opens you up to the same issues that Target is battling.
Sure.
It's not just HIPAA, it's how do you keep that electronic payment
Secure.
form from being hacked. So that gives, as if you didn't have enough issues with HIPAA, this now becomes another.
Actually, electronic
That's why-
payment security is tighter than HIPAA.
Very safe now.
PCI is tighter than
HIPAA.
HIPAA.
You don't save, like my company, we don't save credit cards. We don't do that. There's no way you can use it.
No, but if you're a consumer and, we're all talking about the employer who's going to sponsor this, or you have what if this is not employer sponsored? There are a number of people whose employers don't provide them health care. So they can actually, they'll have to pay for this via Obama or their credit card.
PayPal or, there are systems out there that can solve this issue. I mean, obviously the news comes to Target that this was a big deal about credit cards. There's always a risk. The systems out there employ the way it works. You don't save on your website credit card information. And everything gets tokenized, so it's kind of encrypted, cannot be encrypted.
Right,
So
but
you
you still have,
There's
the
always a-
information is still out there and companies are reporting every day they're hacked. So anytime you.
I mean, crossing a street, you can get it back. I'm still useless.
Well, on that note, thank you very much. And look out for the bus that's going to hit us all.
We have a model for international things, they buy a prepaid document.
Right.
Prepaid card.
A lot of prepaid stuff. I would like to thank everybody for coming this morning. This has been a great session. I would like to thank Fordham University for hosting us this morning, and iCAN-Global for providing the infrastructure to make this happen. And Howard did a great job in assembling a wonderful panel. I'd like to thank the panelists for a lot of information. I think that's sparking a lot of controversy, a lot of discussion, and rightfully so, because this is really a turning point in societal evolution where we're even considering things being done remotely instead of face-to-face. And every industry is being affected in one way, shape, or form. And I think this has been a great example, and I can't wait till the next one.
And let's also say thank you to Windstream for participating and
Thank you for
hosting.
Windstream for
We
hosting,
really
I think,
appreciate
and for sponsoring. Carl, thank you so much. This has been great.
Les, I think we have
Just
one
more
gentleman
thing.
who's
I just
anxious to
want
ask a
add
question.
one more thing, I think there's a big potential in the international market too, because we have recently launched in Middle East and Asia also, so we're expanding over there in OmniMD. So I see a big potential over there where you could actually provide the consulting services, anywhere in the world actually.
Certainly. Thank you all very much.